ولا ماشي الصوت؟
لا حضرتك أمي.
طيب
بسم الله الرحمن الرحيم. Welcome. Welcome in this new meeting of Egyptian Society of Nephrology, CME continuous meetings. I am today to welcome my dear Professor Dawlat Bilal, who will be the moderator of this session. Professor Dawlat is one of my great professors. She is a professor of emeritus professor of nephrology and internal medicine in Asr Al-Aini Faculty of Medicine. She is the past president of Asr Al-Aini Nephrology and Dialysis Center. Professor Dawlat is now the coordinator and the head of scientific committee of Egyptian Fellowship of Nephrology since many years and is continuing with many successes. And she is leading now a teaching program, very successful teaching program in the Egyptian Fellowship regarding nephrology followers. My speaker today is my special friend, Professor Samir Kamal, Associate Professor of Nephrology in Acute University. We are continuing now to speak about kidney disease. We started to speak about glomerular disease, which was held by Professor Ahmed Al-Qurei and Professor Wissam Ismail, and now we are to speak about tubular interstitial kidney disease by Professor Samir. Welcome everyone in this meeting, and I will leave the floor to my Professor Dawlat Bilal to lead the meeting and introduce Professor Samir. Please, Professor Dawlat.
Good evening, everybody. It's my great pleasure to be a moderator for this talk, which seems going to be a very interesting one. Any talk which describes cases and messages is much better than a frank talk about the subject. And this is going to be presented by Professor Samir Kamal, Associate Professor of Nephrology and Internal Medicine, Acute University. And the topic is tubular interstitial nephritis, cases and messages. Professor Samir, you can start.
Bismillah ar-Rahman ar-Rahim. Thank you very much for the SNT board, and special thanks for my friend Professor Yasser Abhamid for this kind invitation. And it's an honor to me to be with Professor Dawlat Bilal, and welcome everybody. Today I'll talk about the tubular interstitial nephritis. This topic is actually diverse and branched, and I tried to summarize and to highlight the important points in tubular interstitial nephritis. The first case, a 56-year-old woman was brought to the ER with history of nausea, vomiting, poor oral intake, and decreased urination for 3 to 4 days. Patient was known to have type 2 diabetes and hypertension controlled on metformin and lisinopril. Patient was febrile, stable hemodynamic and the mental functions. Physical examination was unremarkable. Initial workup was significant for elevated white blood cell count, and the blood urea is increased up to 156 milligram per deciliter, and creatinine was 7.4 with electrolyte within normal range. Urine analysis showed 2+2 proteinuria with sterile pyuria. Lab test showed low complement 3, normal complement 4, and positive antinuclear antibody. Other biomarkers such as CMP, ANCA, liver function test, hepatitis panel, antistrypsin O tetra, and peripheral hemogram, and the blood cultures were normal. The renal ultrasound and echocardiography showed normal findings. The patient was subject to supportive treatment for acute kidney injury. By the second day, her condition deteriorated with further increase in the serum creatinine along with anuria. The patient developed severe respiratory distress from fluid overload and pulmonary edema requiring emergency renal replacement therapy. Meanwhile, renal function and fluid status began improving on renal replacement therapy, and her respiratory distress resolved. The patient was found to have a more and more raised in white blood cell count with predominant neutrophils, and empiric treatment for infection with vancomycin and peptidase was started. The patient was described amyl jaw pain. صوت واضح يا دكتور ياسر؟
واضح جدا.
The patient was described a mild jaw pain that had been persistent for more than a week. Upon examination, she was found to have a tender dental abscess. She clearly denied use of over-the-counter medications or antibiotics. Imaging revealed periodontal abscess with infected tooth, which was drained along with extraction of the affected tooth. Culture from the abscess grew anaerobic streptococci, and the patient was started on clindamycin. Now we can ask a question: what was the cause of acute kidney injury in that case? Was it sepsis-induced acute kidney injury? It is unlikely because the SOFA score in the ER was 0 regarding the respiratory rate, mental function, and systolic blood pressure. Was it perirenal hypoperfusion? It is unlikely also because the patient not improved with fluid resuscitation. Maybe rapidly progressive nephritis, maybe acute interstitial nephritis. So to solve that problem, a renal biopsy was performed, and the picture showed normal glomerulus with diffuse infiltration of the interstitium by inflammatory cells. Histopathology revealed interstitial inflammatory infiltrates with prominent eosinophilic components, most consistent with acute interstitial nephritis. Acute interstitial nephritis, you all know that about 85% of the kidney is comprised of tubules and their surrounding interstitium. So the current understanding of the role of interstitium in the both primary and secondary disease process remain incomplete. The term AIN was coined by Council in 1898 when they provided the first description of the histopathological changes following an investigation of autopsy specimen for patients with infectious disease. Acute interstitial nephritis is a well-known cause of acute kidney injury and chronic kidney disease, and is associated with progression to end-stage kidney disease. The etiology, primarily, acute interstitial nephritis is an immune-mediated kidney injury triggered by the use of certain medications, systemic infections, autoimmune disease, sarcoidosis, IgG4-related disease, or what's called tubulointerstitial nephritis uveitis syndrome. Developed catheterism medication are the most common cause of acute interstitial nephritis, more than 10%, while in developing countries, infectious agents are common cause of AIN. The clinical characteristics of typically patient complaining of general symptoms, the medulla may lead to a defect in the concentrating ability of the kidney and polytepsia. Macropapular rash may be an early manifestation of AIN. Hypertension and edema are not typical feature. Abnormalities in the electrolyte depends upon the extension of the inflammation. Commonly, there is hyponatremia and hyperkalemia. Pyuria and proteinuria are almost always present, and hematuria is present in 19% of cases. With drug-induced acute interstitial nephritis, eosinophilia occurs in about 80% of the cases. The gold standard in diagnosis of AIN is kidney biopsy, but there is no consensus guidelines regarding histologic diagnosis. There is interstitial infiltrate consisting of certain types of cells, lymphocytes, monocytes, macrophages, plasma cells, and sometimes eosinophils. The extension of tubulites according to the extension of the inflammatory process, and there is interstitial edema and interstitial fibrosis often present. The diagnosis of acute interstitial nephritis is challenging because even with kidney biopsy, because low inter-rater agreement among pathologists, commonly associated with other diagnoses of the biopsy, such as acute tubular injury, ATN, diabetic kidney disease, lupus nephritis, ANCA-associated vasculitis. Predominant type of cell infiltrate may raises the possibility of the etiology. As we see here, when the common infiltrating cells is plasma cell, that suggests the etiology of IgG4 or Sjogren's syndrome or systemic lupus, etc. If non-necrotizing granuloma, it may be due to drug-induced or sarcoidosis. If necrotizing granuloma, it may suggest tuberculosis or fungal infection. If there is linear tubular basement membrane IgG staining, it may suggest antiglomerular basement membrane disease or non-steroidal anti-inflammatory or allopurinol or phenytoin or methicillin cause. If there is granular or semi-linear tubular basement membrane IgG staining, it may suggest IgG4 related disease, Sjögren's syndrome, systemic lupus, cryoglobulinemia, idiopathic hypoglycemia, etc. Back to the case, the treatment of oral prednisolone with 60 milligram per day was immediately initiated on the 7th day of the hospitalization, and renal function steadily improved. With eventual discontinuation of the dialysis, the patient was discharged on the 4th week of maintenance dose of prednisolone, and the dose was tapered thereafter. At the following clinic visit in 4 and 8 weeks, renal function has normalized with complete resolution of proteinuria, with no other obvious etiology of acute interstitial nephritis after excluding the possibility of drugs. So streptococcal dental infection was the culprit of AIN, and the treatment was steroid, helped in complete recovery from renal failure. What are the causes of other infections that may lead to acute interstitial nephritis? It may be bacterial infections such as E. coli, Campylobacter, Salmonella, or Streptococca. Viruses such as HIV, CMV, Epstein-Barr, measles, mumps, polyomavirus, or herpes simplex. Spirochetal cause or parasitic such as Toxoplasmosis leishmaniasis, or fungal infection such as histoplasmosis or coccidioidomycosis. The pathogenesis of infection associated acute interstitial nephritis is this is an immune process. Some say that transforming growth factor beta as a major participant in the fibrogenesis may be exciting cause or play a role in the pathogenesis of infection associated acute interstitial nephritis. The clinical presentation is variable depending on the causative organism, ranging from self-limiting renal dysfunction to progressive renal involvement resulting in CKD. Laboratory results are usually non-specific. The renal biopsy is a definitive test for diagnosis, show prominent neutrophilic infiltration and negative immunofluorescence. Extensive interstitial damage can result in irreversible fibrosis leading to progression to CKD. The basic principle of management is renal supportive therapy, limiting the inflammatory damage after treatment of the exciting cause of infection, and controlling the causative infection, achieving immunosuppression. The challenges in the diagnosis of acute interstitial nephritis, because the clinical diagnosis of acute interstitial nephritis is difficult, delayed, or missed diagnosis that's frequently occur. The urine analysis, about 20% of the patient have bland urine sediment. Proteinuria may be misleading. For example, if there is pre-existing glomerular damage, use of drugs that may result in both acute interstitial nephritis and glomerular lesions, such as non-steroidal or the new immune checkpoint inhibitors. Serum and urine eosinophils, leukocyturia, and leukocyte casts have poor sensitivity and specificity. The peripheral eosinophilia only be present in a quarter of the patients. The clinical characteristics of acute interstitial nephritis, such as rash, fever, flank pain, are absent in the majority of patients. And the imaging tests, such as ultrasonography, CT scan, gallium scan, or PET scan, are also suboptimal. Diagnostic biomarkers are generally lacking. The diagnosis of acute interstitial nephritis currently relies entirely on maintaining a high index of clinical suspicion for this disease, and often requires confirmation by kidney biopsy. The biopsy may be not feasible or delayed during optimization in some patients due to underlying bleeding risk. It is likely that clinicians overlook some cases of mild acute interstitial nephritis and ascribe deterioration of the kidney function to other factors such as hypovolemia or natural progression of the chronic kidney disease. Is there a novel biomarkers in the diagnosis of acute interstitial nephritis? Let us to see. This publication said that urine tumor necrosis factor alpha and interleukin-9 improves the discrimination over the clinician's pre-biopsy diagnosis of acute interstitial nephritis. These results suggest the concomitantly elevated level of TNF alpha and interleukin 9 are specific to acute interstitial nephritis and may be useful biomarker to distinguish acute interstitial nephritis from other clinical causes of CKD, of acute kidney injury. Another publication estimating the type of macrophages in the urine, M1 pro-inflammatory, the ratio of M1 to M2 anti-inflammatory when increased was shown to differentiate between AIN and other kidney pathologies. Another urinary retinol binding protein over creatinine was statistically increased in the immune checkpoint inhibitors acute kidney injury group versus the immune checkpoint inhibitor non-IN group. All of these data offer hope for non-invasive diagnostic tests of acute interstitial nephritis. Case number 2, a 57-year-old man presented to hospital complaining of progressive malaise, myalgia, fever, nausea, vomiting, diarrhea, and polyuria and polytepsia for 2 weeks duration. The therapeutic history, the patient was have coronary artery disease and was taking acetyl salicylic acid 81 milligram daily and atorvastatin for 40 milligram daily. He had started taking oral pantoprazole 40 milligram daily 6 weeks earlier due to GERD. He reported have taken ibuprofen 400 milligram for myalgia no more than 3 times over the last 2 weeks. He had no history of renal disease or drug allergies. On examination, the patient unremarkable, and the ultrasonography is unremarkable. Lab investigation show raised renal serum blood urea about 14 millimole per liter and serum creatinine about 300 micromole per liter. There was hyperkalemia and moderate proteinuria, and there was leukocyturia and microscopic hematuria and granular CAS and eosinophils negative. With volume repletion only for 4 days, his creatinine level decreased just to 234 micromole per liter. What to do next? As we mentioned in the last case, they did renal biopsy. The biopsy showed moderate to severe patchy interstitial infiltrates, predominantly plasma cell with some lymphocytes and occasional eosinophils. Immunofluorescence was negative. The results support the diagnosis of acute interstitial nephritis. What was the cause of acute interstitial nephritis? Pantoprazole, or the occasional use of ibuprofen, or low-dose aspirin? Low-dose aspirin was tolerated for years, so it is unlikely to be the cause. When we are suspecting acute interstitial nephritis due to drug-induced, first, we have to identify and withdraw the offending agent. And if we cannot select the offending agent, we can stop or all the used medication and search for alternative for the mostly used medication. We give supportive care and monitoring the kidney function for 3 to 5 days. If the kidney function recovered, complete recovery, well and good. If partial recovery or there is no recovery, kidney biopsy should be taken. And if there is more than 75, conservative management. If less than 75, start corticosteroid. And if corticosteroid is contraindicated, use other agents. The time for occurrence of clinical syndrome. The onset of acute interstitial nephritis can occur from hours to days after beginning the insight agent. About 80% of patients will show renal symptoms within 2 weeks, average 10 days. Back to the case, the treatment. The patient was described high-dose oral prednisolone 1 milligram per kg per day. After 45 days, the patient creatinine level had decreased and plateaued at 145 micromole per liter. Prednisolone therapy was discontinued on the day 98. On the day 168, his creatinine level was 147 micromole per liter, stable. There was no proteinuria and his blood pressure was normal. Upper endoscopy was done and severe esophagitis relieved. The patient not used PPI but used ranitidine 300 milligram, and the reflux was controlled. Drug-induced acute interstitial nephritis difficult in suspicion. The diagnosis more difficult to make in the case of long-term therapy with a drug that can cause acute interstitial nephritis, such as phenytoin or allopurinol, and when delay in the development of disease is months rather than weeks. Up to 40% of patients with drug-induced acute interstitial nephritis may have persistently elevated levels of creatinine, reflecting irreversible kidney damage. The pathogenesis of drug-induced, the drug or its metabolites can reach the basement membrane of the tubular epithelium and will incite an immune injury, either by hapten or prohapten mechanism or molecular mimicry or planted drug antigen. The antigen presenting cell may present the antigen to the naive CD4 T helper cells, and differentiation to T helper 1, T helper 2, and T helper 9 with production of cytokines that attract more and more inflammatory process. Thanks for Professor Saeed, who supplied me with this recently published publication that say what is the famous drugs that involved in the acute interstitial nephritis. Some antibiotics such as beta-lactam and fluoroquinolones, and macrolides, and rifampicin. Some anti-ulcer drugs such as proton pump, and also the H2 blockers may cause acute interstitial nephritis. Analgesics, as we know, non-steroidal or COX-2 inhibitors. Immunotherapies such as immune checkpoint inhibitors. Antiviral agents, anticonvulsants, and other agents, all are involved in the development of acute interstitial nephritis. Well, I stay on the PPIs. Why? Because PPI is one of the over-the-counter medication, and every one of us use PPIs in most of the time. This publication said incidence of acute interstitial nephritis with PPIs varies from 0.8 to 3.2 per 10,000 person year of exposure. However, many PPI associated acute interstitial nephritis cases may be overlooked due to lack of allergic symptoms and delayed development of AIN. Long-term PPI use was associated with 42% higher risk of kidney failure, presumably from unrecognized acute interstitial nephritis. It's very important, very dangerous. This publication also said concomitant use of NSAIDs with PPI significantly increased the risk of AKI. The concomitant use of cephalosporin and fluoroquinolones with PPI was associated with increased risk of incident AKI. Also, male patient and patient using immune checkpoint inhibitors and PPI, with the exception of vonoprazan, concomitantly should be monitored for renal function after chemotherapy. And this meta-analysis of 10 years of publications regarding acute kidney injury and PPI, the increased risk of AKI and acute interstitial nephritis among the PPI users remain even after excluding other exciting drugs that may precipitate AIN. How it works? The proton pump inhibitors deposited in itself or its metabolites in the tubulointerstitium, leading to immune response, lead to interstitial inflammation, acute interstitial nephritis that may lead to chronic interstitial nephritis CKD. The hypomagnesemia that comes from the proton pump inhibitors may also lead to chronic kidney disease. The outcome of acute interstitial nephritis, according to this publication, where more than 1,000 biopsy samples were reviewed, aiming to investigate the outcome of acute interstitial nephritis and stratify the patients into recovered and non-recovery group, the recovery, either complete recovery or partial recovery. They found that proteinuria was significantly higher in patients with no recovery. So when there is proteinuria, that means bad prognosis. And 20-year period of patient follow-up revealed annual incidence of one patient per 1,000 inhabitants. Also, the presence of cortical scarring and active interstitial inflammation carrying bad prognosis of recovery. Also, they found that RAS inhibitors were the most common medication among recovery and non-recovery group, but PPI was carrying a bad prognosis of recovery. Conclusion, therapy for acute interstitial nephritis should not be delayed, as the highest chance of recovery can be attributed to early stages of disease with acute inflammatory signs and low chronic damage in the biopsy. Steroid therapy. How about steroid therapy in acute interstitial nephritis? Steroid may decrease inflammation by reversing increased capillary permeability, suppressing polymorphous activity, stabilize lysosomal membrane, suppress lymphocytes and antibody production. That occur either by genomic mechanisms or non-genomic mechanisms, inhibit several pro-inflammatory molecules such as cytokine, chemokine, arachidonic acid metabolites, and adhesions. Therefore, glucocorticoids can reduce and reverse the mechanism of tubulointerstitial inflammation and additionally exhibit direct effect on the infiltrating lymphocyte by induction of apoptosis. There is a lot of questions about steroid therapy in acute interstitial nephritis, how to adjust therapy decisions to histopathological features, how to treat, when to treat, waiting renal improvement after cessation of the inciting drug or starting early, what dosage of steroid should be used and for how long. That's important questions. These publications answered some of them. They stated that no outcome difference from using oral or pulse therapy. It should be, the duration should be not less than 3 weeks and should be started within 7 days of suspicion. Other causes of tubulointerstitial nephritis rather than infectious causes and drug-induced systemic disorders that have been found to cause acute interstitial nephritis, including sarcoidosis, Sjögren's syndrome, IgG4-related systemic diseases, and systemic lupus. Idiopathic acute interstitial nephritis is noted in certain unique disease entities such as Tenu syndrome, tubulointerstitial nephritis uveitis syndrome, and tubular basement membrane disease, and autosomal dominant tubulointerstitial kidney disease. What's Tenu syndrome? Acute onset of granulomatous bilateral uveitis and interstitial nephritis. Renal involvement usually precedes the eye manifestation, but can occur concurrently or up to 2 months after. Tenu is common, although cases may report in the older ages more than 16 years old. Women are affected more than men with no specific ethnic predominance. The pathogenesis of Tenu syndrome, modified CRB, an autoantigen common both in the sclera and in the interstitium of the kidney, a combination of genetic susceptibility, autoimmune and infectious and atherogenic factors are suspected to play a role. The inflammation in Tenu syndrome is thought to be T lymphocyte driven based upon the histologic finding. The definitive diagnosis, if we see a typical uveitis and interstitial nephritis by biopsy, or uveitis associated with abnormal creatinine, abnormal urine analysis, systemic illness for more than 2 weeks. The uveitis, patient with uveitis present with a painful red eye, typically bilateral. Although unilateral or alternating uveitis can be observed, there is for retinal hemorrhages. May be associated with positive biomarkers such as ANCA, ANA, autoantibody directed against renal tubular cell, rheumatoid factor, hypocomplementemia. In addition, antibodies that react to both tubular and uveal cell have been identified in the serum. The treatment is self-limited. The renal function returned to normal within 1 year. And systemic steroid is usually uveitis. But in severe renal disease, prednisolone 40 to 60 milligram per day for 3 to 6 months is interred, and sometimes mycophenolate mofetil is used when there is contraindication for corticosteroids. What are the differential diagnosis of acute interstitial nephritis with ocular manifestation? Sarcoidosis, Sjögren's syndrome, systemic lupus, Wagner granulomatosis, Behçet disease, infectious disease such as tuberculosis, brucellosis, toxoplasmosis, and histoplasmosis. Antitubular basement membrane disease. This disease presents with acute kidney injury or chronic kidney disease. Polyuria and polydipsia, microscopic hematuria, and proteinuria can be seen. Anti-TBM antibodies are directed against tubulointerstitial antigen, specifically in the kidneys, proximal tubular basement membrane. Antibody formation can be triggered by drug exposure. The characteristic findings that clinch the diagnosis are the presence of anti-TBM antibodies in the serum, interstitial mononuclear infiltrates, and tubulitis, tubular injury on live microscopy, a strong linear IgG staining along the TBM on immunofluorescence. Electron microscopy does not show any immune complex. Autosomal dominant disease. Autosomal dominant inheritance, slowly progressive kidney disease which impaired renal function, typically appearing in the teenagers. A bland urine sediment with no or minimal proteinuria. Medullary cysts may seen on renal ultrasonography, but are not present in most of the cases. Previously was called medullary cystic kidney disease. This classification of the autosomal dominant disease may be according to the defective gene, uromodulating kidney disease, or mutation in the RIN gene, or mucin 1 kidney disease. These three known genetic causes of autosomal dominant tubulointerstitial kidney disease, all of which meet the above criteria, and each of which has distinguished characteristics. Megachoriocytic tubulointerstitial nephritis. This is a rare disease, rare renal interstitial disease entity characterized by large tubular nuclei accompanied by interstitial inflammation, tubular atrophy, and interstitial fibrosis. Approximately about 50 cases of choriomegalic interstitial nephritis have been described, and one in the native kidney and one in the transplant kidney. It typically causes hemproteinuria and progressive renal impairment before the age of 50. It has been associated with mutation in the Fanconi anemia associated nuclease 1 gene that has autosomal recessive pattern. Acute interstitial nephritis may be caused by herbal medicine, what's called Chinese nephropathy. The incidence of acute interstitial nephritis caused by herbs is unknown and often ignored. Single or concurrent use of herbs with therapeutic drugs could increase the potential for side effect. These other causes of tubulointerstitial nephritis and mostly presented with chronic interstitial nephritis rather than acute, like sickle cell disease. And here we can highlight that painless unilateral hematuria commonly associated with nephrocalcinosis and medullary carcinoma. In all cases of sickle cell disease, you have to search for medullary carcinoma. Sarcoidosis, granulomatous interstitial nephritis, Sjögren's syndrome, ureate nephropathy, hypokalemic nephropathy, chronic interstitial nephritis and immune-mediated disease, renal papillary necrosis, and radiation nephritis. My home message, Professor Dawlat and all of others, acute interstitial nephritis is a well-known cause of acute kidney injury and chronic kidney disease associated with progression to end-stage kidney disease. AIN is potentially life-threatening, so accurate and the timely diagnosis of the condition is critical. It has a variable clinical presentation, and the diagnosis is challenging and needs high index of suspicion. The onset of acute interstitial nephritis can occur from hours to months after beginning the inciting agent. Long-term PPI use was associated with 42 risk of kidney failure. Therapy for acute interstitial nephritis should not be delayed as the highest chance of recovery. Treatment of the cause is a must, and steroid therapy is recommended. When unknown cause of deteriorated renal function, please review the medications, think about acute interstitial nephritis, and consider kidney biopsy. And thank you for your attendance.
Thank you, Professor Samir, for this highly illustrative and elegant talk. I would like to welcome Professor Faisal Shaheen, who as well as now. And my dear friends, Professor Said Khamis and Professor Tariq Tantawi, many welcome to be in this meeting. And there is a special greeting for Professor Dawlat Bilal. Professor Dawlat Bilal. Professor Dawlat, can you hear me?
Can you hear me, Dr. Yasser?
Yes, yes. There is a special greeting. There is a special greeting for you from Dr. Ratib Ilwan. He's sending you specific greetings on the chat.
Okay. I have a question for the first case, Professor Samir, if you allow me.
Yes.
You said that the presentation is usually tubular interstitial and with polyuria. The first case presented with oliguria and volume overload. And the second thing is that she had a dental abscess, and probably she took some non-steroidal anti-inflammatory, definitely for the pain. So what do you think? Was she post-infectious tubular interstitial nephritis or also drug-induced? And why did she present with oliguria? This was strange for me.
Okay. As I said, the clinical characteristics of tubular interstitial nephritis is variable. It may be a typical picture, polyuria, polydipsia, peripheral eosinophilia or eosinophiluria, or rash, and sometimes it is variable and the clinical presentation is misleading. Sometimes it is asymptomatic tubular interstitial nephritis and the patient presented late with further scarring. And I said in the first case, the patient denied any antibiotic treatment or over-the-counter medication for pain. Your knowledge. Yes, and this is why the diagnosis was streptococcal infection was the cause of acute interstitial nephritis. So the patient with acute interstitial nephritis may produce the typical picture and may comes by another picture and variable picture. The patient was severe acute kidney injury with anuria, and the patient presented with anuria rather than polyuria and polydipsia, like that of the second case when there is polyuria and polydipsia.
That's right. And if you allow me one more question before the audience, in the second case, it's a PPI, which is an abused drug. I mean, in all cases, almost all cases of post-transplant patients, PPI is always in the prescription. So it's definitely, we see a lot of cases of acute interstitial nephritis secondary to PPIs.
Yes, you are right.
Yes, and
that's
you mentioned
why I
something.
changed the PPI to stress upon among all the over-the-counter medications.
It is one of the over-the-counter medications, definitely. Definitely.
Yes.
And what you mentioned in the
so,
biopsy, that it was predominantly plasma cells. This was strange to me, a little bit.
Yes, actually, you are right.
This is strange. I mean, there are always lymphocytes, monocytes, some neutrophils if it's post-infection, but plasma cells, this is rather strange.
That's why.
Yes.
That's as I said, Professor Dawlat, as I said, even with kidney biopsy, the diagnosis is challenging.
You're right. Yes, exactly.
Thank you for highlighting, Professor Samir, a specific point, and correct me if I'm if I am wrong, that steroid shots or oral steroids are equal in effects and should be both started early with equal efficacy. This is an important message.
Yes.
Okay. Thank you. I think we have Professor Kamal Okasha with us now, and Professor Ali Taha, and we would like to welcome.
Hello.
Professor Professor Dawla.
Can unmute me, please?
You are unmuted.
Yes, Dr. Kamal. Yes, Dr. Kamal.
You are unmuted, Dr. Kamal. Welcome.
No, I am not. I'm muted.
We can hear you clearly.
Yes,
can hear
you. No, it's okay. Yeah. Hello. Assalamu alaikum wa rahmatullah.
وعليكم السلام.
عليكم السلام دكتور كمال، ازيك؟
اهلا دكتور
وحشنا
سمير
ريس.
and excellent talk really actually يعني.
حبيبي
وطبعا
وحشنا
thank
جدا
you Professor
كمال.
Dawlat for the excellent moderation of the session and the Dr. Yasser for your unlimited effort actually. Thank you many times actually for your extended effort for almost 1 year now. Thank you very much and wish you the best always. وعند كل سنة وحضراتكم طيبين جميعا وبألف خير قرب رمضان إن شاء الله. وأنا الحقيقة طبعا دكتور سمير يعني أنا بشكرك. Thank you very much because you highlighted the TIN or tubular interstitial nephritis or EIN as visually acute interstitial nephritis from another very important issue. I mean from another insight. Just tackle it from the immunological point of view, as if you are talking about the allergic interstitial nephritis, which I think by far is the most common cause of acute interstitial nephritis. And that actually what you have in clinical practice. Although acute interstitial nephritis being involved in many systemic disorders actually, and basically lupus, for example, is one of the even diabetes at some instances can be presented with tubular interstitial nephritis and with their sequelae in terms of renal tubular acidosis and so forth. So thank you very much for even by highlighting different syndromes that you mentioned, and you mentioned the pathognomonic criteria for each. يعني أنا الحقيقة طبعا يعني سعيد جدا بوجودي النهارده مع حضراتكم ومع كل الكوكبه الجميله اللي موجوده، اساتذتنا وزملائنا الاعزاء. يعني انا الحقيقه معلش يعني اعذروني بتكلم من الموبايل، فيمكن في حاجات كتيره مش واضحه قدامي، بس انا طبعا دكتور علي طه شفت اسمه موجود، دكتور طارق طنطاوي طبعا زملائنا الاعزاء جنب، دكتور سعيد خميس طبعا اهلا بيك. اهلا دكتور سعيد.
دكتور فيصل شاهين معانا دلوقتي برضه.
دكتور فيصل شاهين اهلا بيك حبيبي، اهلا وسهلا. دكتور احمد مبروك كمان قدامي. دكتور فيصل منورنا.
my computer
Thank you Professor Kamal for this compliment.
دكتور دولت welcome Professor Kamal, and we would like to join you in every meetings.
Yeah,
we'll be very happy.
My pleasure.
Yes.
I'm really sorry actually for not being all the time with you, but it's real. I mean, good chance actually to be with our friends from everywhere. Thank you so much again for allowing us to meet our friends.
Thank you, Professor Kamal, and welcome. Professor Dawlat, we have comments now?
Yes. No, my comments is that I want to thank Professor Samir for a very, very rich talk. Really, it was really very enriching.
Yeah, very.
And for the highlighting of the take-home messages concerning the different causes of the tubular interstitial nephritis and the fact that it is a sort of underdiagnosed disease. It's always a diagnosis of exclusion, and that we should not be late to make a renal biopsy, to take a renal biopsy to confirm the diagnosis when we have the high incident index of suspicion, which we should have really. And of course, above all, the abuse of drugs. Abuse of drugs is very important in this issue. And thank you very much. This was a very useful and rich talk. Thank you.
It was an honor for me to be with you and with my professors actually, and thank you very much for all.
Thank you, Professor Dawlat. Professor Dawlat, excuse me, Professor Saeed Khamis wants to comment?
Yes, sure.
Thank you, Professor Samir, for this elegant presentation as usual, and thanks for all my colleagues.
Thank you.
Especially to Professor Dawlat, Professor Faisal, Professor Tariq, Professor Kamal, Professor Manal, and all Professor and all my colleagues. Just I would like to comment 2 comments, Professor Samir, and 1 question, if you allow. Number 1, regarding the acute interstitial nephritis, I know that it's a challenging problem in diagnosis, but there are some signs or some manifestations can usher to the etiology. For example,
Yes.
for the antibiotic-induced drug
Yes.
AIN, usually there is a rash, and in the non-steroidal induced one there is a glomerular affection due to through the effect on the arachidonic acid metabolism and especially the leukotrienes pathway. So it can lead to glomerular affection in the form of either membranous or minimal exchange, and can lead to nephrotic range proteinuria.
Yes.
Second point is the acute interstitial nephritis, usually associated with what's called, there is discrepancy between the degree of anemia and the degree of deterioration in kidney function. For example, you will find the serum creatinine 2 and the serum hemoglobin can drop up to 7 or 6, because as you know that the erythropoietin produced by the kidney from the peritubular capillary epithelium of the peritubular capillaries. So it will be affected more if there is interstitial nephritis and can lead to disproportionate anemia regarding the kidney function. Last question to you, Professor Samir. Should we start steroid empirically, as you said, because it should be within the first week? And as you know, especially in our countries and in most of the developing countries, biopsy can take at least 2 weeks to be the result is there. So should we start empiric steroid in this case, or should we wait for the renal biopsy result? Thank you so much.
Excellent, Professor Said. Actually, from your comments, yes, there is some things to raising the suspicion of acute interstitial nephritis, actually, as you said. And regarding the use of steroids, yes, I agree with you to start steroid before the appearance of the biopsy report, if it is delayed, because as I said, early starting treatment is better outcome for the patient. And
yes.
Say what will be deficient for the patient if the diagnosis is rather than acute interstitial nephritis.
Almost nothing will happen.
Because in this issue, the differential diagnosis of acute interstitial nephritis mostly in need for steroid therapy. So I agree with you to start after withdrawing the inciting agent and after treatment of the infection, you have to start corticosteroids unless there is a contraindication until the proof from the biopsy report.
Okay, thank you so much.
Thank you, Professor Said. Thank you very much.
Welcome, sir.
Professor Kamal, do you want to comment?
Assalamu alaikum again, Professor Samir. I agree with you, Professor Samir, for that issue of starting steroid once you even initially diagnosed as tubular interstitial nephritis. But in actual fact, the problem is the diagnosis of the leukocytic cast or white blood cell cast. It needs some hyperpolarized microscope, which is not, or some staining actually, by what we call it right staining. It's not available all the time at the lab. So that's that's what makes us reluctant to start steroid. But if the data even from the urine analysis, I can start steroids by even the maximum dose, even bus steroid, especially in cases of allergic interstitial nephritis.
As I said, excellent, Professor Kamal, there is no difference between pulse therapy and oral therapy regarding acute interstitial nephritis. Actually, you can start 1 milligram per kilogram per day, a maximum 16 milligram per day, and for a minimum of 1.5 months. And then, according to the response, we can start tapering of the steroids.
Professor.
Yeah.
Professor Daulat.
Thank you.
Professor Daulat, can I proceed?
Yes, of course, you can proceed. Go ahead.
Okay, we have Professor Faisal Shaheen, please.
Thank you very much. It's an excellent talk, but I miss probably 10 minutes because of technical issue with my computer. So I don't know either for Prof. Samir. He spoke about herbal medicine and traditional medicine, which we have it so frequent in our community. And I think one of the major cause of interstitial nephritis. I don't know, probably I missed that, but if I miss it, please don't comment. It's my fault.
Sorry, the voice has interrupted. Please, Dr. Yasser, Professor Faisal, what's his
Professor
question?
Faisal is specifying, he's asking about a point that he missed. Professor Faisal, Dr. Samir did not get your point clearly.
No, I'm speaking about herbal medicine and
Herbal medicine, yes. Herbal medicine with
traditional.
acute interstitial nephritis. Yes,
Yes.
I mentioned this issue in the last pieces, last slides. Yes, herbal medicine or Chinese nephropathy may involve it in acute interstitial nephritis, especially when it's taken with non-steroidal anti-inflammatory drugs or as when combination of herbal medicine together. And I see myself several cases of acute interstitial nephritis with herbal medicine. Actually, agree with you totally, Professor Faisal.
We had so many actually. That's why, and it become, you know, some people are taking from anyone in the street
without source. Yes, for losing weight or for gaining weight also.
Yes. Thank you.
Thank you for your comment. Thank you for your comment, Professor Faisal.
In continuity with Professor Kamal comment regarding costs, I think that it is not the issue of specific techniques. I didn't see a cost in annual analysis, I think more than 20 years ago. They are very reluctant to check costs.
So
I think the
biopsy is a
problem
must. So biopsy is a must.
Yes.
It's not that for techniques.
Yes, the definitive diagnosis is biopsy actually. Yes.
Biopsy is very, I mean, you know, tubular edema and distortion of the tubular cells. It's very characteristic actually. There is the pathology of acute interstitial nephritis. Yeah.
Dr. Dawlat, we have questions on the chat.
I don't know. I don't see them.
Please check. Okay, so there is from Islam Abu Ni'ma. For how long do you recommend conservative management? To start steroids empirically or take a biopsy first? I think you clarified this point.
We answered this question. When you suspect and acute interstitial nephritis and you exclude all other causes, you can if the patient is stable, you can take the biopsy and start steroid. It is better if it is allowed fast report. Okay, wait and see. If it is delayed, as Professor Kamal said, we can start empiric steroid until the report of the biopsy. So, but we cannot take a renal biopsy unless the patient is a stable patient and there is no risk of bleeding, because sometimes the acute interstitial nephritis patient is a critically ill patient and the risk of bleeding may occur. So we can conserve or start steroid therapy, and the patient when is stable, we can take a biopsy.
Okay, and this is a point that you said, Professor Samir, and I do not totally agree with you, excuse me, that it is difficult to diagnose interstitial nephritis clinically. I think it is easier than you said, much easier than you said to diagnose it clinically and suspect it clinically.
When you suspect, Professor, yes, when you suspect acute interstitial nephritis, start treatment. When the patient is critically ill, and the characteristic features is atypical, what can we do? If the patient is stable, take a biopsy. If the patient is not stable, conserve resuscitation. We can start at this moment steroid therapy, then we take the biopsy.
Okay.
I have a comment.
Continuity with this.
Can I have a comment?
Yes,
yes, Professor Dawlat.
Yes. In both cases, you described they were diagnosed by biopsy,
Yes.
right? And you started treatment after the biopsy. Can you
Yes.
give us an algorithm for clinical diagnosis? Because if the biopsy is going to be 2 weeks delayed, then I have to do something. I have to have some firm points for the diagnosis of the case. Before we used to say that the urine is the poor man's kidney biopsy. Is there a urine picture which is indicating, or I mean, makes you think that this is a case of acute interstitial nephritis, apart, of course, from eosinophils in the urine, which probably needs a very good lab to see or to read that the urine has eosinophils. How can I have something strong to let me start steroids 2 weeks before I get the real diagnosis? There
Again,
must be,
Professor.
it's an
Okay,
acute
okay.
kidney injury, all right.
Yes,
Acute renal
yes,
failure, all right.
Yes, we can say that. The patient comes with acute kidney injury, okay? We exclude the pre-renal and post-renal causes.
Yes.
And we suggest acute interstitial nephritis from the history, from clinical examination, from the presenting investigation, what we have. If there is typical presentation, there is mild proteinuria, hematuria, there is rash, skin rash, and medical history of inciting agent,
Drugs.
or there is concomitant infection, systemic infection that can cause acute interstitial nephritis. So the diagnosis is priority. So you can manage according to this priority, according to the facilities of renal biopsy in your center. If it is fast, wait for the biopsy report. If it is delayed, you can start diagnosis. That's what I said.
Right. I don't see why a biopsy should take 2 weeks to be read. This is not acceptable. I mean,
sometimes it is transported. Actually, in the far governorates, there is no pathologist actually. So the specimen is transported to Cairo or to Alexandria or whatever to be diagnosed. So it may take time actually.
Yes. Oh, yes, I know. I can imagine this can happen. Yes.
One Professor Dawlat.
Please, Professor Ali Taha.
اولا السلام عليكم.
عليكم السلام.
احنا طبعا انا سعيد بالكوكبه العملاقه الموجوده، وسعيد بالاستاذ سمير على المحاضره الشيقه. حقيقه معلش انا كنت بسمعها من الموبايل، كنت جاي سايق، ففي بعض الحاجات نزل مني، ولكن انا ليا بعض الكومنت انا سمعتها بس عايز استوضحها اكتر. How about use of steroid empirically؟ ده لسه انت كنت بتقوله، بس معلش انا الخط كان قطع مني فما عرفتش الكومنت بتاعك. انا سعيد بوجود اساتذتي وزملائي الاستاذ الدكتور دولت والدكتور ياسر والدكتور كمال والدكتور طنطاوي وجميع الاخوه والدكتور فيصل شاهين. احنا سعيد بسماع صوتهم. وحقيقه انا حضرت الحلقه الاولى والثانيه، وكان مارفلس برزنتيشن دكتور سمير، هايلايت جود هايلايت على التوبل انترستيشن نوفايتس، وخصوصا اوفر كاونتر ميديكيشن البي بي اي والانالجيزك والحاجات دي كلها must be ان احنا نحطها considered in our suspicion on our diagnosis when facing a cases of tubular interstitial nephritis. How about use of steroid؟ هو طبعا الدكتور سمير البيوبسي ما بتاخدش اسبوعين كتير، احنا بنبعتها سواء القاهره او كده زي ما بتقول بتاخد لها ولا حاجه، ولكن انا اي ثينك ان احنا مع الاكوت انترستيشن نيفرايتس مع الاكوت كومبرومايز اوف ذا بيشنت could be ناخد بيوبسي ونبدا السترويد until the result of biopsy appear.
دكتور علي، اولا انا برحب بحضرتك وبشكرك جدا، وزي ما حضرتك قلت وده كلام اللي انا قلته، لما يكون العيان عندك definite diagnosis or high index of suspicion and the presentation favor the diagnosis of acute interstitial nephritis and the patient can withstand the renal biopsy, take a biopsy, and if the report is will come fast, ننتظر لغايه لما تطلع نتيجه البيوبسي. لكن لو كان هيسافر وهيروح مكان تاني وهياخد زي ما قال الدكتور سعيد اسبوع او اسبوعين كويس، انا مش هستنى لغايه لما تيجي الريزلتس اوف ذا ريبورت اي كان ستارت ستيرويد. ده ملخص الستيرويد ثيرابي في الاكيوت انترستيشال نيفرايتس regarding او individualized according to the patient, according to the presentation, according to the facility of the center treating the patient.
To Samir, another question, if you allow me.
Yes, welcome.
About the degree of proteinuria. You said that in the first case, some sort of proteinuria. How about the degree of proteinuria in tubular interstitial nephritis?
Typically subnephrotic. Typically subnephrotic range proteinuria, but sometimes there is bland renal urinalysis without any evidence of proteinuria. But typically subnephrotic range. Tubular proteinuria.
دكتور سمير، وما نسيتش انا لو دكتور سعيد خميس طبعا والجميع الاخوه، انا مش عايز انسى حد من الكوكبه العملاقه اللي موجوده، واحنا ان شاء الله الدكتور ياسر بمجهود جبار بيبذله. نشكر على الكبير بصراحه اللي بيبذله في الاي اس ان تي ميتنج.
Thank you, Professor Ali. I am really happy this session with this joint meeting for our professors. Really a great attendance, and welcome all of you, a great share of you. Professor Kamal wants to comment again.
Yeah, it's just a very brief comment actually for this. You know, the discussion about acute interstitial nephritis is very interesting actually, especially there is no real consensus about the management of acute interstitial nephritis, and all are something you got it from the textbook or from the our clinical experience. But what I want to say actually in terms of regarding the acute interstitial nephritis is considered as one of the renal emergencies, similarly like the rapidly progressive glomerulonephritis. Exactly. What I used to do actually since I was, practicing in nephrology more than 15 years or 20 years ago, and this is I've got it from my professor, Dr. Ahmed Shukr, while I was in Canada, and he taught me that take urine sample for every patient you are suspecting whatever, either nephritis or tubular interstitial nephritis or whatever, and you examined under microscope. And fortunately we had microscope in the clinic at the time, and he taught me how to just to detect the cast, the different cast, if it is red cell cast, if it is dysmorphic red blood cells, if it is even white blood cell cast, is considered as renal emergency. So what I use, what he taught me actually to do, and this is I try to convey to all my juniors actually, to teach them how to just to be very practical. Take the sample, urine sample, examine it. If you got any active sediment, by the way, any active sediment, it's considered as renal emergency. And according to the clinical scenarios that you have, if it is, for example, accompanied with dark urine, so and so and so, then this patient is emergency. Take your all specimens that you can take, serology, and take even renal biopsy, and start treatment immediately. Don't wait even the result of the serology. And of course, the steroid, pulse steroid, and in some cases, if the clinical scenario, for example, telling it is considered like lupus nephritis or flare of lupus nephritis, and you start the immunotherapy, even immunosuppressive therapy. So I agree again with you, Professor Samir, if you have a high degree of suspicious actually, and you examined and the urine sample under microscope, and you find that there is any kind of active sediment, like as Dr. Dawlat mentioned, eosinophilia in patient with allergic acute interstitial nephritis or leukocytic cast, which is pathognomonic for all kinds of acute interstitial nephritis, then you start the empirical treatment. Sorry for being, maybe too long comment, but I think it has some meaning actually. Thank you again.
Thank you very much, Professor Kamal. As I
You're
told you,
welcome.
it was said before that the urine analysis is a poor man's kidney biopsy.
Yes.
So,
Yes.
so
Yes.
it's very important
This
to
is
know how
relevant,
to
yes.
examine a urine sample under the microscope. And this is one of the
Yes.
MRCP questions. One of the
Yes.
practical questions or an OSPI question is to give you a urine sample to read, to see a white cell cast. I know Yasser doesn't like casts, it seems, but a white cell cast is very pathognomonic of some sort of infection.
Yes.
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 And one thing, Professor Samir, you said in the first case, which was rather strange, is that complement C3 was decreased. Does this have any significance to a reduced complement?
Yes,
In the first case, you
hypocomplementemia.
said C3 was
Yes, in the first
decreased.
case, yes. Yes,
Mm.
I know that I mentioned that in certain cases of acute interstitial nephritis, hypocomplementemia may be present. And
This is
that's,
very confusing.
yes, very
Actually,
confusing.
this is very confusing.
That's why I said in the differential diagnosis is rapidly progressive glomerulonephritis versus acute interstitial nephritis. Yes, I agree with you, but sometimes it's present, and some biomarkers like anti-nuclear antibody may be positive, ANCA may be positive in some cases. That's why the diagnosis of acute interstitial nephritis sometimes is challenging.
It's very confusing.
Yes, and very confusing. Yes.
Yes.
And sometimes acute interstitial nephritis come with another pathology.
Another pathology. Yes.
Like lupus nephritis. In lupus nephritis, we have glomerular lesion and we have tubular lesion. Sometimes in diabetes, we have a glomerular lesion and we have a lesion. If acute interstitial nephritis occur in diabetic patient.
Yes, I'll tell you how things can be very confusing. Your first case was a diabetic person, lady who had a tooth periodontal abscess, so this is infectious, and she had a low complement. I would say, and she was oliguric, right? I would very easily go for post-infectious GN with oliguria and acute renal failure.
Yes.
And if it was due to
you are right.
So it's very confusing. Really.
And that's yes, and the diagnosis comes from the pathology report.
Yes, the pathology made the diagnosis. I would easily go for, if it was a staphylococcal infection in a diabetic patient, as SARN, which is a staphylococcal related GN. And this one has a reduced complement. Yes, and it's C3 is always confused in these cases.
You are right.
So it can be very confusing, really. So the biopsy is very important. Very important. And the urine. Definitely the urine.
That's why the biopsy and urine analysis and careful clinical history from the patient with clinical examination together will reach the diagnosis of the patient.
Exactly, yes.
Thank
you very much, Professor. This is a brainstorming case, which is very important. I mean, at the end of the day, it's an acute interstitial nephritis after all this. So it's very useful to really see such cases. Yani. Thank you very much.
Thank you. I'm really happy to be with you, Professor David, actually.
Thank you. I totally agree with you, Professor Kamal, that it is an emergency and it lies under the big title rapidly progressive renal failure. Rapidly progressive renal failure, which is one of its entities, rapid progressive glomerulonephritis. And for the urine analysis, I always remember my Professor Kamal Saadi during his rounds, usual morning rounds, which were in the very early mornings. He leaves any investigations and asks about, give me a good urine analysis. And if we're doing investigations, immunology, MRI, CT, and nothing, he needs all of this and asks about urine analysis. We have a question in the chat from Dr. Masoud Khairi and a comment from Professor Tariq Tantawi. From the chat first, excuse me, Professor Dawlat, Dr. Masoud asks about if there is a genetic predisposition for cases that caused by PPI. All of us intake of PPI. Why
Dr.
is
Yasser, can you allow my video to be on, please? Because I want to see you.
Sorry?
My video is muted, yeah. You know,
Okay.
you guys are intending me.
Okay.
Hello, Dr. Tariq.
Regarding the question,
Okay, please, Dr. Tariq, تفضل.
Really, السلام عليكم الأول. Many thanks, Professor Samir, for your elegant presentation, and many thanks, Professor Dawlat, for your wise moderations. Actually, we meet not so much of these scenarios, and actually, I think my attention will be depend on the progression of the kidney injury or the pattern of progression. If it's fast, I will start steroids. If it's not fast, I will delay and I can take a biopsy first, because we do not like to give a rationale to start a biopsy in just a suspicion of AIN. Actually, we meet many scenarios for the abuse of use of steroids scenarios. I'm willing to take a biopsy, depend also on the rate of progression of the renal injury. At the end, many thanks for the fruitful discussions and the fruitful knowledge that you deliver to us, Professor Samir.
excellent,
كل سنة
Professor
وأنتم طيبين.
excellent. كل سنة وحضرتك طيب. You are extremely right, and we said if the patient is presented with rapidly deteriorated renal failure, that is the case, I can start steroid empirically. And if the patient presented with a cold case, or the patient was stable, you have to take the biopsy first, and not
Meet
to
a
be
lot
in a
of
hurry.
cases before, just when withhold. Yes, when withhold the offending drug.
Yes, in the algorithm,
Spontaneous recovery.
Yes,
So
yes,
there is no need
in the
to
algorithm,
start steroids. Yes,
yeah, you are right. I showed an algorithm for this drug-induced. If the withhold of the exciting agent lead to complete recovery, no need for anything, no need for biopsy from the start. But after 72 hours, the patient showing no improvement, you have to take the biopsy. That's what I mentioned before.
Yes.
Thank you.
Yes.
Professor Samir, I said a question up from Dr. Masoud Khairi, if you have an answer about the why specific persons have the interstitial nephritis. Is there any genetic predisposition or just by the chance?
I'm afraid I'm not read anything about the genetic variability for the PPI-induced acute kidney injury, actually. There is no publication said it is common in certain ethnic or genetic variability. But the incidence is present and stated. The relationship between acute interstitial nephritis and PPI is stated. The statement I said, concomitant use of PPI with another inciting agent make the possibility of acute interstitial nephritis is higher, but I am afraid I know nothing about the genetic variability for the PPI-induced acute kidney injury.
From Abdurrahman al-Maghrabi, our coordinator, he wants to clarify a point, specifically for how long we can use steroids and when we'll stop it.
Yes, there is no consensus report upon this point, but we start 1 milligram per kg for a minimum of 44 days, and according to the response, we can start tapering. 3 to 6 months is stated in certain situations, but the majority said according to the response of the patient. When you get a complete recovery, you can start tapering of steroid.
Okay, thank you. Professor Saeed Khamis wants to comment.
Yes.
One point to Professor Yasser, I wanted to add regarding the value of eosinophiluria in diagnosis of AIN. Eosinophiluria is neither specific nor sensitive to diagnose AIN, because it can occur in other situations, as you know. So we should not overestimate the value of this eosinophiluria. If you remember, maybe we couldn't answer the questions. What is the stain to be stained with? Hansen's stain and so on. So, but
Hansen's stain.
Hansen's, yes.
Hansen's stain, yes.
But it is neither specific nor sensitive to diagnose AIN. And thank you so much.
But it gives a clue. It can give you a clue, Professor Said.
Yeah, just not more. Yeah, I mean, it is.
I think in the view of this clinical picture,
as we said, excellent, Professor Said. But as we said, we are collecting data together to reach the diagnosis.
Yes. Yes.
If it is present, it add a point for diagnosis, and if it is not present, it not exclude the diagnosis.
Right, you are. Yes. Thank you.
By far, the leukocytic cast is the pathognomonic for acute interstitial nephritis in general, not specifically hypereosinophilia, as the Professor Said mentioned. We just think about it in patients with allergic acute interstitial nephritis, who, for example, taking some antibiotics or some contrast or whatever. Yeah. Thank you.
The voice is gone.
For all, I guess. Oh, yeah.
Kamal, Dr. Kamal, unmute yourself. Unmute yourself. Your voice is away.
Unmute myself. Yes, I did.
Yes, you are
I
muted.
did.
Okay.
Yeah, I just was. If you didn't hear me, actually, by far the pathognomonic finding in urine for acute interstitial nephritis in general is leukocytic cast. If you go for subtypes of acute interstitial nephritis, for example, the allergic acute interstitial nephritis, the pathognomonic is eosinophiluria. It's well known that eosinophil is the leukocyte for hypersensitivity. As a problem is just the staining, yeah.
I'm afraid leukocytic cast, Professor Kamal, thank you. I'm afraid leukocytic cast is not present in all cases of interstitial nephritis, and the sensitivity and the specificity for this in diagnosed acute interstitial nephritis is not that much higher.
Okay.
You hear me?
Professor Dawlat, we have no more. Yes, it's clear. Professor Dawlat, we have no more comments.
No, maybe one last comment is that PPIs are by far the most abused drug for everyone.
Yes.
Yeah, yes. I mean, every other prescription PPI is there.
That's true.
So
that's true. And regarding, yes.
The question by Dr. Masoud is quite significant, that some people are prone to develop acute interstitial nephritis from these drugs. Why are they prone? Probably in concomitant with other drugs, maybe some genetic predisposition, many reasons, because it's so commonly used. And but we do get cases with acute interstitial nephritis from PPIs. That's my final comment, Yani. Thank you.
And it's very significant comment, Professor Dawlat. Really, why some get a disease and some do not get, in spite of this very wide use of this drug. And really, it is the difficult drug to stop, not the wide use. And difficult patient do not agree. Usually, any patient does not agree to stop the drug, this specific form of drug. It is the protective drug.
The message, Professor Yasser, the message is when use PPI, select the case. And sometimes when used with another inciting agent, you have to monitor kidney function. When used, should be used for a short period of time. Not we see patients on PPI for years, which is nonsense actually, especially in chronic kidney disease patients. So that is alarm for all. When using PPI, use it when necessary and for a short period of time. And when it is taken with another inciting agent for acute interstitial nephritis, you have to be cautious.
And this is a uniform comment regarding the side effects of many and many kidney diseases, including even transplant. This is a uniform comments on all aspects. So, Professor Dawlat, no more comments and no
Well,
more.
thank you very much.
Just I want to add very little and small comment, actually, Dr. Samir.
Yes.
In clinical practice, actually, we are not intending to diagnose acute interstitial nephritis. It comes with many other diagnoses you are in mind. For example, a lupus, it may be presented with a tubular interstitial nephritis, as Professor Dawlat mentioned. Post-streptococcal infection also could be presented, or for any other systemic disorder can be presented with acute interstitial, and it comes, in fact, with the diagnosis by biopsy. But in the clinical scenario, that if even just you are 100% sure about the diagnosis on clinical ground, you may start short course of non-steroid steroid, and as I remember, actually 20 milligram once per day, and for 5 days to 1 week, and that's all, and the problem will be finished. But if we want to go in details, so we have to take renal biopsy and manage accordingly.
Okay.
And thank you again for your very nice cases and very nice, I mean the selected topic actually. السهل الممتنع اللي بيقولوا عليها دكتور سمير. شكرا جزيلا، وشكرا دكتور ياسر على اختيارك الموفق دايما، وشكرا لكل السادة الحضور. أستاذتنا الفاضلة الأستاذة الدكتورة دولت، حضرتك منورة كل الأماكن يا أستاذتنا والله بجد.
الله يخليك. I really want to thank Professor Samir. This is a very rich session.
Yeah, ما شاء الله.
Thank you very much.
Thank you very much. Thank you very
I
much.
say hi to Dr. طارق حبيبي، دكتور علي طه، دكتور سعيد خميس.
شكرا.
Excuse me.
Who's else? Dr. Yasser, of course. طبعا. Dr. Yasser.
Dr. Dawlat, excuse me to close, please.
Yes. Thank you very much.
I am really happy with this
Dr. Saeed Khamis, bye.
Which is rich by our
Dr.
professor.
Samir, see you.
Thank you.
Which is very rich by professors' comments and interactions. Very rich session, and thank you, Professor Samir, for enriching this session with your challenging cases and challenging points. Thank you, Professor Dawlat, for highlighting the challenges in the cases and in the points, and enriching the sessions with discussion. Thank you, our attending professors, Professor Kamal Okasha, Professor Faisal Shaheen, Professor Saeed Khamis, Professor Tariq Tantawi, Professor Ali Taha, and thank you all. Excuse me to close this very rich session.
1 minute.
And wait me on 13th of April, right, Dr. Yasser?
Yes, Professor Kamal.
We'll discuss it later. Ramadan Kareem.
Allahu Akram. We'll discuss it later. Allahu Akram. And the next session will be by Professor Iman Sarhan next Wednesday, inshallah. And excuse me to close, and تصبحوا على خير. السلام عليكم ورحمة الله وبركاته.
السلام عليكم.
السلام عليكم.
See you all.
السلام دكتور سعيد.
دكتور سعيد فين؟
ايوه دكتور كمال.
مستخبي بقى.
دكتور سعيد اظهر وبان.
نقول للدكتور ده وهي طيبه.
ازيك يا حبيبي؟ وحشنا